Good afternoon. Hi, we're welcoming you to our presentation today, the panel discussion entitled Advancing Organizational Health Literacy Through a Health Literacy Learning Collaborative. We're really happy to have you here this afternoon, and we will be sharing our presentation and then hopefully having plenty of great discussion following that. My name is Mary Ann Abrams. I'm a pediatrician in the Department of Primary Care at Nationwide Children's Hospital in Columbus, Ohio, and also an assistant professor at The Ohio State University College of Medicine. I've been working in the health literacy field for nearly 20 years now. My major focus throughout has been on sort of real world implementation and developing and implementing tools and resources to foster what we now call organizational health literacy. And for the purposes of our discussion today, I'm also the co-investigator for our Office of Minority Health funded Advancing Health Literacy Franklin County grant. And that is focused on creating a sustainable organizational health literacy infrastructure and capacity here in Columbus and Franklin County. My co-presentation colleagues today are Jessica Chevrolet. Jessica is a health literacy specialist and grant coordinator and senior research associate for Advancing Health Literacy Franklin County, and she's based here at Nationwide Children's Hospital. She brings together her background in research, teaching, and public policy to help lead development of resources, training, and tools to support organizational health literacy. And our other colleague today is Allison Riggle, who is a project manager here at Nationwide Children's Hospital, and she works primarily providing support for our kindergarten readiness and high school graduation initiatives, including coordinating the Imagination Library and Reach Out and Read. She also works with our NCH Health Literacy team, especially in developing and implementing our Health Literacy Learning Collaborative. And that is what you will be hearing much more about throughout this afternoon. So with that in mind, I'm going to go ahead and get started. And then, as I said, we will follow that with discussion at the end. I know that you can enter your questions, and we have wonderful support helping us with that. And if you'd like to add in your name, your role, your organization, you can enter that in the discussion area, and that way we'll be able to get a sense of who's all here and capture that information as well. So with that, we'll go ahead and get started. Our learning objectives today are to identify the opportunities and challenges related to developing an organizational health literacy learning collaborative, to help you understand how a health literacy learning collaborative can enhance current organizational health literacy efforts and align with your organization's mission and goals. And finally, to use the tools and resources we'll discuss today to collaboratively increase organizational health literacy capacity. By way of background, I already mentioned that a lot of this work is supported by the Office of Minority Health funded grant entitled Building a Health Literate Community Toward an Equitable Response to COVID-19. So this was built on organizational health literacy to address challenges related to COVID, but also to other health disparities. Franklin County Public Health is our lead agency. The Columbus Public Health Department and Nationwide Children's are the two collaborating organizations, and we're also supported by the University of Hawaii at Manoa in some of the evaluation work. Want to acknowledge all the members of everyone's teams and highlight a couple additional members of our team who are not presenting today, but whose work was very important, is very important to our efforts. That's Hannah Bradbury, Kasia Weldon, and Abigail Wilson. So you've heard me talk about Columbus, Ohio, and Franklin County. Columbus is in Franklin County, Ohio. We're the state capital, one of the largest cities in the state. And you are probably familiar with the health literacy maps that have used the data from national health literacy surveys to provide estimates of the prevalence of health literacy in different geographic areas. So this map represents Franklin County. And as you know, the orange and red represent the areas that are at highest risk for limited health literacy. And in our area, we call this sort of an inverted T. These are a lot of the areas that we serve at Nationwide Children's, and a lot of our collaborating organizations do as well. But as we all know, health literacy is important regardless of where you live. We predicate we predicate the health literacy learning collaborative work on several key foundational pieces. I know that all of us are familiar with the definition of individual or personal health literacy, and Healthy People 2030 tweaked that definition just a little bit. But the really exciting thing about Healthy People 2030 is that they defined organizational health literacy for the first time. And that is the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform their health-related decisions and actions for themselves and others. So together, this definition of personal and organizational health literacy constitute health literacy itself. The other really important pieces of Healthy People 2030 are that they explicitly stated that achieving health and well-being requires eliminating disparities, achieving health equity, and attaining health literacy. So they really linked health literacy with health equity in a very clear, I would say, bold fashion. And they noted that the health system has the responsibility to provide clear, understandable information and make sure it's understood by those who need that information. So it was really valuable to finally have this stated in a very prominent way by an important, robust body. That led to our two major grant goals, and it's the second goal that we're going to be focusing on today in this presentation. Our second goal really focused on creating a sustainable community organizational health literacy model and infrastructure for Franklin County. We wanted it to be here when the grant was over. We're really trying to build capacity and put together a sustainable infrastructure. And while some of the work was focused on reducing COVID-related disparities, we want that to be transferable to other health disparities and ultimately to promote health equity. So you'll hear us using our abbreviation for Health Literacy Learning Collaborative, the HLLC. So just to make sure that you're familiar with the acronym that you might be hearing. This and the next slide are slides that we actually shared in an informational call before the collaborative began. So you'll see this use of the second person because we really wanted to reach out and be engaging to the people who expressed interest in participating. And we wanted to answer the question up front, what is a learning collaborative or the health literacy learning collaborative? And it really represents a group. We wanted to bring together diverse health-related organizations that serve Franklin County, where they would come together to make improvements in organizational health literacy. And we use and we will use the framework related to the 10 attributes of a health literate healthcare organization, which you're probably familiar with from 2012, that the Institute of Medicine Roundtable for Health Literacy members described. And then to help evaluate and monitor progress, we chose the Enliven Organizational Health Literacy Self-Assessment Resource, because that is mapped to the 10 attributes, and then it has a set of various sub-items or sub-attributes to help tease out different components of those 10 attributes overall. We really told the teams that they would be using their findings from looking at the 10 attributes and reviewing their initial Enliven assessment, and then to really consider that in terms of their mission, their strategic plan, and their organizational priorities, and that they would, at the end of this collaborative, develop a health literacy plan. And we recognize that some might be wanting to focus on a small component of that, or maybe they're a department or an area within a very large organization. So they may want to choose a focused health literacy plan. And some were bigger organizations that wanted to really go all in or had the capacity to do that, or maybe they were a small organization that really wanted to focus on health literacy. So their plan would be related to the whole organization. The idea behind a learning collaborative is that it's a 6-month period, and it's purposefully 6 months because the idea is to accelerate everything. Otherwise, we tend to plan, and then we plan some more. So we would accelerate learning, adoption, testing, and then ultimately, hopefully, spread of health literacy related interventions, and then integration into their standard principles and practices. It's predicated on the idea of all teach, all learn, so that we all learn from each other. Initially, teams will be learning a little bit more from those leading the collaborative, and then eventually we all will be and were and did learn from them. And that shifts over that 6-month period. So we learn from each other. At the end of those 6 months, the participants really become health literacy experts and health literacy champions. They develop their plan, and they have hopefully built that internal capacity to advance as health literate organizations. And that will address our goal of creating a sustainable Franklin County community organizational infrastructure. We would be providing materials and resources, and we really told them up front that evaluations are important and they will not be infrequent, and we thank them even before they started. I'm not going to spend a lot of time on the 10 attributes of a health literate healthcare organization. I'm pretty sure that most of you are familiar with these, the 10 attributes. Pointing out just a couple, the first 1 or 2 actually look broadly at ensuring leadership and engagement, integrating and planning health literacy into like a lot of the work you do. There are several related to the workforce, a lot that talk about meeting the needs and involving consumers and end users, effective communication, and materials. The other major shift or adaptation we made was we talked about the 10 attributes of a health literate health organization. Because some of our organizations, including the 2 colleagues on our grant, they're public health agencies, so they're not really healthcare organizations. So we did talk about health literate health organizations. And this is just a cover of the Enliven self-assessment, and it is accessible online as a tool. You heard me mention that the collaborative runs about 6 months. We built that into 3 in-person learning sessions. These were half-day sessions. Lesson learning session 1 and 2 were relatively close together. And then they had time to really work more deeply. And then we just had our final learning session in mid-April, where all the teams reported out their results and their plans. In between the learning sessions, we had virtual Zoom calls that were about 90 minutes, and those were action periods 1, 2, and 3. This is just a slide to remind all of us that we kind of took a QI approach. While we were very directed in how we guided them through the learning collaborative, we really wanted them to use a QI approach, meaning learning as they go, using small or slightly larger tests of change, PDSA cycles. But this was a developmental process. It was not just take this and plug it into your situation or your setting. So with that, I'm going to hand it over to Jessica, who's going to give you a better sense of what it takes to plan this activity. Jessica?
Thanks, Marianne. The next slide. So before we even started recruiting teams to participate in the Learning Collaborative, we created 2 documents. The first is a summary document that included like the purpose, what the Learning Collaborative is, outlining who can participate, benefits of participation, and expectations. The descriptive document, similar items, just a lot more detail on those topics, as well as a very detailed timeline for the learning sessions and the action periods. So we also did 2 documents for 2 reasons. The first being, as we're recruiting people who are just kind of interested, we gave them the summary document, and as they became more interested or wanted more information, we gave them the detailed document. But also for leadership support, we really wanted leaders to be supporting their team in this work so it is sustainable. So that's why we also created the summary document that is a little shorter and easier to get through. After spreading the word through lots of emails and communications to our partners, we held a virtual informational session for prospective teams to hear a little bit more about the collaborative and the expectations, but also really gave a chance for prospective participants to ask questions and concerns about the amount of time it may take or the capacity they may have. And then the final part of the recruitment phase was filling out a profile document. So this profile included information about their organization, who their team leader was, who their team members were, as well as their contact information, and then questions along the line of why they wanted to participate in this collaborative, what they were thinking about doing for their plan or their project, if they wanted it focused or organizational wide, specifically how they were involving leadership within this plan. And we did have them sign and agree to all of the expectations as well. Next slide. So pre-work. After teams officially signed up, along with the Enliven, we sent them 5 pre-work items. These are core and fundamental health literacy works. I'm sure you will recognize all of them. Many are short, and like Marianne talked about before, the 10 attributes are really key to their work and to the Enliven. Some items, like the guidebook, are longer works to get through, but it was more to become familiar with, not that we wanted them to read it cover to cover. Next slide, please. So through the grant, we were able to provide the groups with many additional learning opportunities. Specifically in the collaborative, we were able to provide the opportunity to sign up for the IHA certificate program, as well as a 12-hour reader-friendly plain language materials workshop. So some of these are taught by Dr. Audrey Riffenberg. So not everyone on the team had to participate in this workshop, or even some people that they designated who were the right participants for this workshop attended. We also adapted the CDC Making Health Literacy Real, the Beginnings of My Organization Plan for Action. We adapted it for our purposes as well as a tool for the teams. Next slide, please. So we could probably do a whole presentation just on this slide, but communication is an essential part of organizing the collaborative and communicating with the teams. And this involved a lot of moving parts. From the beginning, from even the pre-call about the Learning Collaborative, we set expectations with the teams of their responsibilities, as well as what they could expect from us. We sent calendar invites right after they signed up, so it was held on their calendars. Set up 2 main contact lists, purposely, one with all of the team leaders, members on there on like a Word document, so you could just quickly glance at like who was on each team, and then a more detailed Excel document that had everyone's names, all their emails, their roles, their credentials, etc., as more of a comprehensive document that teams also had access to as part of a way to collaborate with each other, as well as 2 different email groups. One we had for everyone, participants, organizers, anyone related to the work. We would send out general emails, but also we created individualized email groups for each team. One, it saves time, so you don't have to find everyone's email every time, but also so it's easier to track your communications with that specific team. They feel like it's more individualized, personalized, that they can ask you questions and they're not writing to the whole group. And also when they send you documents or things like that, it's easier to find in that same email chain. So we'll talk a little bit more about what those emails look like later on. But the contact list, the email groups, the calendar invites, those are all things that are like constantly updated as the teams evolved and changed, added new members. So that's something that is continuing throughout the whole 6 months. We also sent out regular reminders to help the team stay on track with assignments and upcoming either events or talks or other grant opportunities. We utilized Dropbox for all our documents and resources. We gave all the teams almost everything in print version, but we also wanted to have it electronically available to them as well. And Dropbox was a resource that teams could have easy access to. That was something external from us. So finally, one thing that was very important with effective communication was involved ordering supplies and tracking attendance. So you want upfront to know who exactly is on the team, how many people are there, how many people are going to be coming to your event, because you need that information for lead time to order supplies and printing and pens and binders, all the little things that help make it run. So having that upfront helps a lot with that type of preparation, as well as attendance. So we needed it, one, for grant purposes to track who is coming, but also to see if the teams are really engaging, who's participating, who may not have been able to attend, but may want a recording of part of a session. So those are good things to track as well. Next slide, please. So first, pick your dates and book the room as early as possible. Getting space can be incredibly difficult. We are really lucky to have this great auditorium at Nationwide Children's, but it is very hard to book and get the dates that you want. And I'm sure that is the case for many of you trying to find space. So before you even start recruiting or anything else, get that room booked and pick your dates. You can see slightly, maybe Marianne can point it out on the right, on the edges of the right and left photo. We intentionally set up the room to have a collaborative atmosphere, along with things like even table tents with the people's names and the logo of their organization. So it was easy to find, like, oh, I heard that person talk about something really great earlier, and look around and find their logo and go over and talk to them. So that is something we intentionally did to foster collaboration. If you make binders yourself, it takes time. So just plan for that time and the lead time for ordering from a print shop and putting it together. You can see we provided the teams with a lot of materials and resources, which they appreciated a lot. As well as even in future sessions, we hole punched the handouts we gave so they could add to that binder as well. Pens to take notes, lanyards. We actually collected the lanyards and table tents every time to reduce waste. And that's something also to keep track of. It's easier to add 5 new lanyards than, 50 more. So in general, organization of all of this is paramount. So the teams can focus on learning. They don't need to worry about anything else, and they can really focus on what we're trying to teach. Next slide, please. So I'm going to hand it back over to Marianne to talk about the structure of the sessions, and I'll finish up with more supporting materials.
Thanks, Jessica. So at our very first learning session at the very beginning, we really wanted to kind of get them engaged and be thoughtful. So we posed the question using Mentimeter, who or what inspired you to join the Learning Collaborative? And it was really, I would say, heartwarming, gratifying to see the things that came up. Some people had talked to somebody, Greg or Alex, about participating, but at the front and center, there was a main concern about health equity, equity, justice, patients, And then things like learning and knowledge, collaboration, opportunity, and community. So, and a lot of other really great descriptors, but it was, we didn't know what was going to pop up here, and it was really nice to see. So that was a great way to begin the collaborative. This is just the agenda from the first learning session. Others were similar, but they did evolve. You'll see this first learning session looks a little bit more, I don't even want to use the word didactic, but it was more didactic. But we tried to make these engaging and interactive and use videos as well. But we structured that half-day session. We wanted everybody to get started with a common understanding. So we had a health literacy fundamentals presentation, and we tried to invite other members of our grant team to make these presentations so they didn't always hear the same people all the time. Then we talked about health literacy and action. So you learned about the problem and what can we do, and a major focus on plain language and teach back, but other interventions as well. I'll tell you a little bit more about our ability to have an improvement advisor who also grounded them with a description of the model for improvement, quality improvement methods, organizational change, and the importance of involving patients, families, and clients. We wanted, again, everyone to have that common understanding. We had working time following the more formal sessions, and lunch, had some additional discussion and wrap up. And then we were able to have the room available for a little while longer if people wanted to stay and discuss with us. The second learning session moved into several equity related concepts, health equity and health literacy, the intersection, and health equity quality improvement toolkit, and some written materials discussions as well. And another teach back session where they were more active and not just having it explained to them. And then, as we talked about the final session, they presented their team report outs. This is one example of how we managed the action periods. We were very intentional and thoughtful and organized, I'd like to think. At the end of every encounter, whether it was a learning session or an action period session, they explicitly had an assignment, and we went into great detail. Take a look at your health literacy organizational planning booklet. Make sure that you've either completed your Enliven assessment or you reviewed it, and start to think about what those results tell you. Look at page 7 in your plan. And then we wanted them to do a small test of change each time. And we had that content outline on page 12, and then to keep us updated about any changes in their team composition. So we've tried to let them focus, as Jessica said, and as you'll hear us say again and again, we wanted them to be able to focus on organizational health literacy and not, oh my gosh, what do I do and what do I say and what do we report out, etc. As I mentioned, we were fortunate to have Gail Nielsen, who's got an international reputation in organizational improvement. She's affiliated with the Institute for Healthcare Improvement, and served as an improvement advisor for us, gave those presentations, provided coaching, feedback on the virtual presentations and the final learning session, and helped to observe the big picture of how these teams progressed and evolved over the course of the collaborative. So we were really greatly fortunate to be able to work with Gail. In addition, we had some added value presentations because there was just all this richness that we wanted to be able to share, but we couldn't squeeze it all into those existing formats. So we were able to provide a presentation on numeracy with Chris Trudeau. Many of you also know, in addition to Chris, Sabrina Kurtz-Rossi, who gave a foundational discussion about the culturally and linguistically appropriate services standards, because that was an important component of the grant. And then one of our colleagues, Stephanie Shepard, recorded a presentation, sort of a basic presentation using practical tools to assess materials. and that's available for them to take a look at anytime as well. So I believe I hand it back over to you here, Jessica.
Thank you. So I'm going to talk about all the planning tools and materials that we gave our teams. So first, to start with, 2 free planning tools. As mentioned before, the plan for action we adapted from the CDC just to meet our needs of what we wanted the teams to do. We kind of used it as a workbook throughout the process. As you saw on one of the previous slides, we tailored our assignments to directly reference specific pages within this book and to help them with their progress, specific questions to ask along the way and answer. And then as well, we provided them with PDSA templates, examples relating to different topics as well. And you are also available, the booklet is free and available to download as well and adapt as long as you credit the original source. Next slide, please. So the first supporting material we provided was the Always Use Teach Back toolkit. It is, I'm sure it's familiar to a lot of you, and we even gave the module as an assignment during one of the sessions and then talked about it the next time to see what they learned and what they got out of it. It was a great experience. Next. And Gail, who Marian just mentioned, was able to provide various job aids and other informational tools to the teams relating to their projects and what they were working on. Next. And with the grant, we're able to provide the opportunity to complete the IHA certificate. And we, through the grant, we have a lot of additional health literacy 101 trainings that we do within the community and for partners. And we provided them with a resource document that we created for those trainings as well. Topics and including organizational health literacy, the care environment, plain language and teach back, culture and language access, reader-friendly materials, and other selected references as well. Next slide, please. So Dr. Audrey Riffenberg was able to provide the reader-friendly training, which was a great and valuable resource to our participants, as well as a checklist. But as I mentioned before, not everyone was able to attend that that training. So we also, and Stephanie's talk was about these next materials. So the CDC Clear Communication Index, and then the PMAT, along with the SMOG as well. We those 3 together we used as a tool, free tools, and taught the participants about how to use them, and they could use them with their colleagues and share them with their colleagues to review and improve materials. Next slide. So the emails, you may not be able to read everything on here, but we wanted to give an example of the detailed emails that were sent to each team afterwards. So it begins with a list of all of the attachments. So we sent the attachments to every team through the emails, but we also put them in the Dropbox as well, so they could find them in their ever preferred method. The assignments broken down by what they had to complete, when they needed to submit it, what they needed to email or do in the process. So, and putting the most important information first, like what it was due versus other things that they could register for or sign up to do. So really putting that in order, because it is a long email, and sent multiple reminders. Sometimes it would just be a reminder for one specific thing, because sometimes we would have different due dates. So this one thing was due this week, this was due the next week. Really having that structure in there for them as well. We really wanted to practice what we preach, using health literacy principles, making a lot of complex information more digestible and easy to read through this technique as well. Next slide, please. So the templates were a really valuable resource for us as well as the teams. We provided report out template, PowerPoint templates to all the team for every learning session and action period, including their final presentation about their final project as well. So it allowed the teams to focus on what they needed to do. They didn't have to start from scratch, creating something new, reinventing the wheel. They could just focus on their actual projects and what they needed to report out. And it promoted uniform reporting. So as they're reporting out to all the teams, you didn't have to think about, oh, it's switching from this to this. The teams themselves had already filled it out so they could understand the other teams as well. Next. So I talked about the PowerPoints, but an amazing resource that Hannah made for us was an Excel template for the enlivened results. So the teams put their pre-test scores in there, their post-test, and then it automatically created a graph for them. And then this was also a standardized graph that they used for their final presentations. So also easy to interpret. Everyone made the same ones, didn't have to explain every time you went up there what they were looking at. So that also helped to save time and really standardized that. And finally, the last again, the plan for action was a great template that we provided digitally and print that they also were able to turn into us at the end. Next slide, please. And lastly, our evaluations. So we had a lot of evaluations during this collaborative. Some were grant specific that we had to do for every grant activity that we were doing outside of the collaborative as well. So there were some of those throughout every session. There were overall session specific evaluations or after presenters we had, especially at the learning sessions. And then next. Yep. So, and the last evaluations were some of the most important, and they were a little longer as well. We asked the team leaders to fill out a specific evaluation about the progress that their team made through the learning collaborative and their satisfaction with it. And then finally, we had the participants fill out an evaluation as well to see if there is any changes in their confidence or conviction in what they've learned and their satisfaction with the learning collaborative as a whole. Next. I will hand it now over to Allison.
Okay. Thanks, Jessica. So I'll be discussing the results of the Health Literacy Learning Collaborative. The collaborative did just finish in mid-April, so we are still receiving leader and participant evaluation responses. But over the next few minutes, I'm going to highlight the teams, their projects, and some of the preliminary results. Next slide, please. So participation, our initial roster included 13 teams and 56 participants. And then we can update that to our final enrollment, which was 10 teams and 50 participants. So many teams added and or switched out participants throughout the collaborative. This happened especially after the first learning session as teams began to focus their projects and identify key players. Some of the reasons for the organizations that withdrew included the healthcare system was just overwhelmed, slammed last year at the height of the respiratory illnesses last winter. And then also there was unexpected time and resource constraints and internal capacity. But the really neat thing was that all three teams that withdrew demonstrate continued interest in engaging in organizational health literacy in other ways. Next slide, please. So this is the distribution of our teams. We had several sectors represented in the collaborative, including public agencies, healthcare organizations, and community-based organizations. So you can see here the distribution with 6 teams were in healthcare, 1 community-based, and then 1 public agency. Okay, next slide, please. Okay. So organizations joined the collaborative with a project or a need in mind. We had participation from larger and smaller organizations. Some teams represented smaller departments within a much larger organization. And these factors, wherever their location was or what their situation was, influenced the team aims and their areas of focus. Each team determined if their project would be organizational focused or department focused. All teams conducted and participated in an Enliven assessment evaluating either their department or their organization. Each team was able to develop their own approach for the implementation of the Enliven assessment. And what we found was that the Enliven assessment was applicable and accessible across the different sectors that were represented. So based on the projects and their Enliven results, teams selected one or more of the health literate health organization attributes to integrate into their project plans. Next slide, please. So as Jessica had mentioned, we provided an AIM template for teams, which was very helpful for them. And each team used that document to develop an AIM specific to their project. 7 teams selected organizational aims, while 3 teams chose more department-focused aims. The 2 examples that you see on screen demonstrate some of the difference in language used depending on the scope of their project. This was a learning process, not only for us, but also for the teams themselves. Teams revised their aims as those small tests of change that Marianne mentioned help their projects evolve. So the final aims, which is here what you see, these 2 examples are final aims, they were presented at the last collaborative learning session along with the final Enliven results. So next slide, please. So teams, as Jessica said, were also given a template to enter their pre and post Enliven results. It was incredibly helpful for both the teams and for us to get those results back in a very organized, neat way, very accessible. So here, this picture is some of our team leads on stage after they had presented their projects. In a few moments, we're going to look a little bit more closely at those pre and post results. So next slide, please. So using the insights from the initial Enliven results, teams then selected attributes that best aligned with their project and their overall aim. As seen here, most teams chose to focus on 2 attributes. We had a couple that chose more and one that chose less, but teams found that it was beneficial to focus on fewer attributes, especially when selecting the more detailed attributes, such as attribute 1. Next slide, please. So as mentioned, teams came into the collaborative with an area of attention or an area they wanted to work on. The Enliven results help these teams give their project or their need a specific health literacy focus. So here you can see the diversity of attributes represented across the teams. Most teams did focus on those attributes related to leadership, workforce development preparation, and patient access. So next slide, please. So towards the end of our work together as the collaborative, the teams implemented the Enliven assessment again. This is the result of their increase or decrease or lack of change in their pre and post Enliven. 8 of the teams saw an overall increase of their Enliven scores. The team shown here that experienced a decrease in score was actually a team that had initially, they moved from an organizational focus at the beginning of the collaborative to a departmental focus that was more applicable to the work that they were wanting to do. The team shown here that didn't see a change or fluctuation, did see fluctuation within individual attributes, which I promise we're going to get to here in just a second. So no change or decrease in the scores can also occur as respondents learn more about health literacy and kind of gain a better understanding and appreciation of the components of each attribute, what goes into each of those pieces. So what's really nice about this is each of these teams now has a baseline moving forward with their work. So next slide, please. Here we go. This is an exciting one. So this is an example of our pre and post Enliven results from one of our teams. So you can see the fluctuation in the attributes between the pre and the post. Some went up, others stayed the same or similar, and others decreased. One interesting pattern that we saw across all the organizations is those organizations that selected to focus on attributes 1, leadership, and 3, workforce preparation, tended to see growth in other attributes as well, even if their work hadn't focused on those other attributes. Next slide, please. The participants were sent surveys at the beginning and end of the collaborative, as Jessica mentioned. This was to assess both their conviction that organizational health literacy is important and their confidence in applying health literacy tools and principles. 27 participants responded in the pre-test and 30 responded in the survey. So here you see the average scores. We asked the participants to rank their conviction and confidence on a scale of 1 to 10, with 10 having the most conviction and feeling the most confident. Both scales did see an increase. Prior to the collaborative, participants rated their conviction at a 9, but after the collaborative, participants rated themselves as having the highest level of conviction. Prior to the collaborative, participants rated their confidence at a 7, and after the collaborative, they rated their confidence at an 8. So next slide, please. So this is another exciting part. What I would like to do is to share some testimonials from 2 of our teams. This first team is our maternal home visitation team at Nationwide Children's Hospital. They share some of the key takeaways that they gained from the collaborative. Now, just from background, they focused on attributes 3 and 9. I know many of you probably know 3 and 9 off the top of your head, but for those that don't, those are health literate organization prepares the workforce to be health literate and monitor progress. And a health literate organization addresses health literacy in high-risk situations, including care transitions and communication about medicines. So go ahead and let's play the video.
The key things that originally stood out to me from the very first session that we went to was how important it was to include the people that would be testing the change or using the change with them first. We polled all of the home visitors in our department. It came out that they collectively, pretty strongly, a high percentage of them needed more information around when their clients felt like they were being pushed to accept a procedure or didn't know that they had a choice in a procedure that was going to significantly affect their care. And so they would tell their home visitor, I don't know why this is happening. I don't really want this, but they didn't know how to talk to their provider about that.
We took the home visitor input and created an informed consent training.
The thing I'm most proud of in the HLLC participation is just educating our staff and making them aware of informed consent, bringing informed consent to light so that it's one of our focuses.
Something that I'm most proud of is our ability for our home visitors to use that information practically to affect clients' lives. Here's a short testimonial.
We talked through what informed consent means, that she's allowed to have her questions answered, that it's important that it be answered in a way that she can understand. Health literacy means she has to be able to understand, use the information that's given, and make a decision for her in her best interest and for the best interest of her child. So she was able to do that. She advocated for herself. She got her questions answered. And in this case, it doesn't always happen, but in this case, she was able to do a VBAC.
Being Hispanic, I have seen in both my professional and personal life the adverse effects that can happen when people don't understand the information being presented to them. So I'm so thankful for the initiative, the time and the hard work that everybody's doing in order to try and turn this so serious issue around.
Yeah, as you saw, this team engaged with their change users to better understand the needs of the providers, the population. They were able to identify the concerns with informed consent, were able to create the changes necessary to have the moms they were serving better understand consent and to be able to advocate for their needs. Next slide, please. This second video is from the health equity team at Nationwide Children's Hospital. They focused on attribute 2, which is to integrate health literacy into planning, evaluation measures, patient safety, and quality improvement. Let's go ahead and play the video, please.
Hello, everyone. I am Toyetta Bernard Kirk. Today, on behalf of myself and my co-chair, Ty Young, we both are NCH Health Literacy Champions, and we are excited to share our journey with the endocrinology type 2 multidisciplinary team for Health Equity Health Literacy Pilot Program.
Hi everyone, my name is Mary Joy. I'm one of the diabetes nurse educator. Another diabetes educator with us here is Michaela Cook. And through this program, we have been able to identify super users. And our super users are going to help us to broadcast the health literacy throughout the endocrinology. We were very happy to find that the whole department was excited and they were able to come on board with this program. Thank you.
I'm Lena Mamley. I'm a physician in endocrinology. Our team of super users has been able to develop a health literacy and teach back survey, and we were able to capture 75% of our department staff. Through the survey, we were able to distribute a badge buddy that teaches about health literacy and health equity and teach back, and we plan to use those results to further our knowledge and competency in health literacy and health equity as an endocrine department.
The lead physicians of the Type 2 multidisciplinary clinic. So the health literacy program was an eye-opening experience for our group as we were able to learn about how we can incorporate simple but yet important facets of teach back in our everyday practice. One example of this is just by reframing the question to see how much the patient has learned. So instead of us asking, do you have any questions? We can simply reframe this by saying, what questions do you have? And this may elicit a more meaningful response.
Hi, I'm Kristen. I'm the pharmacist with the Type 2 diabetes team. By participating in the pilot program, our team realized how understanding the concept of health literacy and identifying methods we can improve our communication with patients and families is vital for us to be able to achieve our goal of best outcomes for all of our endocrinology patients.
So this, there's just such a great example is the endocrinology Type 2 multidisciplinary team pilot program. They engage with nurse educators, physicians, pharmacists, social workers, and other team members to develop this idea of super users engaging in promoting health literacy and implementing the teach back tools. And next slide, please. So now I'm going to hand the slides back to Marianne so that she can share more about the lessons that we learned throughout this process. Thank you.
Okay, so at the end of the collaborative of the six and a half months we spent together, we began our last session with a very similar question about who or what inspired you, but instead of to join, we focused on throughout or during their participation in the HLLC. And again, we saw some really great things. First of all, I think we really built teams, communities, pulled people together and got them working together, even though they were all very busy in the middle of still coming down from COVID in the winter times and all the public health activities that were going on. We had measles in Franklin County over in December and January, so lots was going on. But people were still inspired and working collaboratively together and still focused on equity and patients. And they felt positive that they had made progress and were going to a better, moving toward a better future in terms of patients and also this work, patients and clients, as well as this work. So we learned a lot of lessons along the way. We should probably add that little icon for the PDSA cycle that represents sort of taking a QI approach to this work. Jessica really outlined nicely a lot of the logistics and implementation, important points, things that make things run smoothly. And again, several of us have mentioned this, but I really feel that a really important role that whoever leads this kind of work plays is let the teams work on health literacy and do the background work for them. So they knew where they were going, what to do, where to find what they needed. And then they were the ones who became the experts in where can we apply this within our organization? Where are the needs? Where do things match up? As opposed to saying, goodness, where do we even begin? Team outcomes, we've talked too about how teams evolved over time, and we mapped them through draft aim, a refined aim, and then finally a final aim. And we let them assess those outcomes or decide what their outcomes were going to be. We also provided coaching because some teams were really deeply grounded in quality improvement methodology, and for others it was rather new to them. So we tried to help coach them in terms of setting aims and what is a PDSA cycle, and we were really looking for smaller tests. The action period calls, you'll see on the next slide, were wonderful and challenging. We made them 90 minutes. We didn't want them to be longer because we were trying to be very respectful of the busyness of every single person involved. And we initially added one of our added value calls into one of the action period calls, and it made it very tight. So that's why we moved those added value calls to a separate optional timeframe. But even then, we wanted teams to be able, every team wanted to hear from other teams, and we wanted every team to be able to share because there was so much great work going on. So there was this tension between trying to keep everybody on time and move them through, provide feedback and coaching. Gail was able to do some of that coaching and feedback in the chat, and we would try to highlight a pearl or an opportunity from each presenter. But that was the tough part, and we still haven't figured that out. We could have breakout sessions, but then you don't get to hear the other teams. So we're working on that. Materials, again, and a syllabus, as Jessica described, planning ahead. We felt a little like, oh my gosh, are we using too much paper? But from the preliminary evaluations we've gotten back, did people just want things fully electronic? Did they want both? Did they want just hard copies? And most of them really do want both. They really wanted that materials that they could make notes on and keep everything at the ready and all together. But the electronic format was really helpful as well. And then trying to figure out the right balance between giving them a complete tool or a one-page summary or just a link. One of the things I think that this presentation and preparing for it is helping us do is to be able to put together a syllabus, which I think will also help people plan ahead and think about that for the next time so they'll know exactly where they'll be going as the 6 months proceeds. And then, as we've talked about the evaluation, the change in knowledge was required for the grant, and that was managed by our evaluator. We purposely kept the evaluations for the sessions and the presentations one item, like one or two items. My level of knowledge before I heard this presentation was X. My level of knowledge after this presentation was Y. My overall satisfaction with this session was X, and a little bit of room for comments. So we really, because they were getting lots of surveys, we didn't want to overdo that. We used QR codes and asked them to do it then and there in the moment. And then we had those longer, more lengthy and much more detailed evaluation surveys to really get at how did this all this planning, all this thoughtful work, did it meet its mark? And that's part of the evaluation. And the other part is, did you make progress? And where did you make progress? And where do you see yourself? And what was most helpful? What was least helpful? So that, as Allison said, we haven't had time to dig into those results yet, but I'll share a couple of those ideas with you. And these are just two of the insights that people did share about the action period calls. There were so many organizations, a lot of information, so sometimes people felt a little bit overwhelmed. And they were rapid fire, so they were not as interactive or engaging. So we're still thinking about that. With the larger all participant survey, so far when these slides are put together, we've had 30 out of the 50 respondents. And the question is, we all know that how likely you are to recommend something is a marker for their overall satisfaction. And nobody said they were unlikely or not likely to recommend participation in the collaborative. More than 2/3 said they were extremely likely to recommend it, and the others were also likely. And these are just some of the examples, the little quotes that people said that they would recommend it. They felt it was an excellent way to network and learn best practices, really appreciating that how one small change can start to drive progress, and they were glad to be involved. This is a summary from the leader survey. So there were 10 teams. We're trying to get 100% response, and we had 8 responses when we put these slides together. And this, to me, it was like, oh, I really am interested in how they'll answer this question. What progress do you believe you will make in 3 years? So real life, not just by next week, toward becoming a health literate organization. And again, all of them said they would make either moderate or major progress. And that too was very gratifying. And I think moderate progress is a realistic response. And again, just some quotes. They found that the Enliven scores helped to increase visibility of the work, and that cross-divisional dissemination they're recognizing how other areas can work together and share this work or spread this work. And then they want to expand their champions. And then this was a little bit more of the specific work that particular team was doing. So to kind of summarize overall, we saw really nice progression from October of last fall, when the teams really arrived to learn, and they were listening, they were drafting and testing in November and December, and starting to turn that into what they would do and formalizing things, thinking things through, designing what it would look like. And by the end, they were putting some things in place, implementing, starting to spread, and thinking about how they can hardwire and sustain some of the work. Now, not all of them are ready to just plug this into standard operating procedures, but they had shifted very much to the right side of this arrow. We saw paradigm shifts in their overall thinking. They moved from having really no health literacy infrastructure to thinking about policies, procedures, standing committees, and that again ran the gamut across different organizational types. They moved from learning about health literacy to teaching and implementing and standardizing and sharing that themselves, because they became and evolved into experts. They were testing ideas. They're now working on embedding these new processes. A lot of siloed organizations, but we found that the teams started talking to each other and working, and a lot of that even went on behind the scenes. We don't even know about all of it. We did on one of the surveys ask about new partnerships internally and new partnerships externally. And again, we haven't had a chance to look at those results yet, but we'll get a sense of that as well. And I'm really pleased that we moved, health literacy so much is focused on clinical care and clinical health, which is wonderful. But we all know that social determinants of health and all the other parts of health are important beyond the traditional healthcare clinical delivery system. So by folding in public health agencies, other agencies, and community-based organizations, we got people thinking that way, realizing how health literacy fits with being a health-related organization, and helping people recognize those opportunities. And even within a health system, don't forget about those staff that maybe aren't on the front lines with a patient or a family in a room, but oh my gosh, they're on the phones, they're on the registration desk, they're transporting people, they're building Epic templates, things like that. So those shifts were really gratifying. Some kind of key wrap-up takeaways. These ideas of systems, building organizational infrastructure, a lot more leadership buy-in and support, and an unwavering focus on how health literacy and equity are tied together. The new relationships I've mentioned, sharing resources, information, and support with each other. And then the teams themselves, I think, really did develop an esprit de corps, working together and getting ideas and implementing and testing and implementing those. And kind of alluding back to what I was just talking about too, to be able to recognize, oh my gosh, this is health literacy. It's not just the reading level of your handouts. It's so much more than that. And to be able to express that and demonstrate that to colleagues is vital. We saw deeper understanding of what it really means to be a health literate organization and how important it is to align organizational health literacy with your mission and focus. You can't just say, oh my gosh, this is another thing we have to do. You really have to seek that alignment, and that will provide synergy and hopefully garner support. Really need to understand what your clients or your patients and families are experiencing so you can involve them in the work and tailor the work to them. Building understanding and experience with different methods of improvement, and building infrastructure to avoid this just being a project that you tick off and then you're finished. Really understanding even more about equity and recognizing opportunities where you can identify health literacy, leverage these tools, and then embed these practices, again, full circle to achieve mission and equity. And then thinking about alternative communication approaches. People were folding in videos and other unique approaches. So going forward, when a collaborative ends, it officially kind of ends, but many are interested in continuing to somehow stay in touch. So we're going to kind of come up with a way to provide those opportunities for them, maybe quarterly, to connect with each other, to support their continued work and share. We're going to offer another learning collaborative again in the fall to continue addressing that goal of a sustainable infrastructure. We'll be looking at those evaluation results and then using a lot of the discussion we had today to really describe this and share that with others if they're interested in replicating the project. So there's a photo from our last learning session, and we want to thank everyone in that room and the people who weren't able to attend, and thank our colleagues and our partners. So with that, we wrapped up, and I think we have a few minutes for us to answer whatever questions you may have. All right, so this is where I get nervous about what I do next. But I'm going to try to do what I need to do, and we'll find out. I'm going to stop sharing. That's comforting. I didn't know what I was going to see when I stopped sharing. No questions. Okay. Jessica, did anybody chat in what their roles were? Is that in the discussion at all?
I am unable to see that right now.
Is that on the other screen? What'd you say?
Mm-hmm. Yes.
That's the old one, so that's not ours. Okay. Sounds like there's a couple of questions. Okay, Andy, I see you're from Iowa. That's where I spent my initial health literacy years, so welcome. What do we have? Patient family education coordinators, health plan, epidemiology, communications, Oregon. Great. So if I ask you a question, you can either chat it in or speak up, or I don't know if they can unmute or not, but what brought you into this session? Hi, Greg. Good to see you. Can you see the discussion, Jessica? I can't. Brianna, could you tell us or read the questions or whatever it might be there? Okay. I'm going to ask Jessica and or Allison to share one thing that surprised you from this work. I think I kind of shared some things I was surprised or pleased.
I don't mind going first. I think one of the things that I was really pleased with, I like to see systems connect, and the fact that we brought in organizations from across different sectors, saw the way that they were interacting not only with their own projects and their direct partners that made their work was going to implement, but they also were working together and made a larger network. So I really feel like we made some really strong connections across Franklin County. So I wouldn't say that surprised me, but it's definitely something that pleased me for sure.
Yeah, I was gonna say something similar. I was able to also sit in on all the reader-friendly trainings and watching the teams collaborate in that way. And then we had one person from one giant hospital system in our area actually help out with another giant hospital system's their team's work as well. So that was really cool to see collaboration in that way as well.
I think that's a really good point. Where in areas where people may otherwise compete, they came together and were working together.
It does look like we have a question. If you want me to read that out loud. Vincent said, I appreciated the learning of recognizing that health literacy is more than just plain language and words. Did you encounter any resistance to this idea? People who were hesitant to think beyond just words?
Jessica, you want to take that first?
I don't think that we did. I think the first learning session really set a foundation of like what health literacy is and how much it encompasses. And I think there was a lot of aha moments during that session of just exactly the reach of health literacy. So I don't think we had any resistance to it.
Yeah, I would agree. I felt like we didn't even really talk about like written materials till the second one, and they were able to partake of Dr. Riffenberg's training, but we really emphasized equity and all the different ways that's impacted. We did see a lot of interest in language and culture as well.
Mm-hmm.
So we have a question from Nicole about the different kinds of organizations. Do you want to summarize those, Jessica?
Yep. We had 3 teams from NCH, but overall representing 4 hospital systems in the area. We had 2 public health agencies, 1 justice and policy organization, as well as a smaller nonprofit.
The smaller nonprofit focused on food advocacy, education, and access. So they were really looking at that dimension, and they focus on underserved and under-resourced areas. And then the Office of Justice was a really interesting addition because they focused a lot on methadone, people who were in jail and going home and involved with addiction treatment. And they really, that was pretty impressive in terms of how they applied these these principles and strategies to a very specific issue and made really nice progress. Hulda asked about a quick SWOT analysis, so we can wrap up with that. All right. Jessica, do you want to give us a strength, and then Allison think about a weakness, and I guess I'll think of an opportunity and a threat.
Strength, part of it is I think how well our group worked together to organize everything and get it all prepared and ready for the team. I think organization was key to the team success.
Great.
I would say a weakness was just the time capacity that Marianne mentioned with the action periods on, not the action periods, but the action periods on the Zoom calls. So that was a challenge because the teams wanted to present, they wanted to connect, and there was just limited time to do that. So I would say that was a weakness that we're working on for future collaboratives.
And I'll combine the opportunities and threat. The threat to me is always the collaborative's over and people go back to the old days. And I think that's the last thing you want. And the whole purpose of this kind of a project is to embed it so deeply that it becomes part of their culture. And I think that's where the opportunity lies, because we did apply it that way. And we're going to continue some nurturing, but hopefully that opportunity to continue to spread that. And then to maybe invite them back to do presentations for a future learning session or added value call may also be an opportunity. So I think we're at time. We appreciate everybody's interest and participation, and thank you very much. Have a good evening, depending on what part of the country you're in. Thank you.
Thank you.